Sure, what the heck. So hi, everybody. My name is Dr. Anna Silenzi. I'm an interventional cardiologist here at Frederick South. I've been here practicing for about 17 years. I'm a local, born and raised here. So we're just gonna have a general overview about women's cardiac health, okay? Please interrupt me if you want, anytime. I will have some time for questions at the end though. So I'm sure everybody in this room knows somebody that has died from breast cancer. I know we're talking about heart health, but I'm going to talk about breast cancer for a sec. So everybody either knows somebody that's died from breast cancer or knows somebody that's died from breast cancer. We talk about breast cancer a lot. We talk about how to prevent breast cancer. We talk about, making sure, there's a whole month, of course, dedicated to breast cancer, which actually is October. So, encouraging women to, get their mammograms. What we don't talk about all that much, and is kind of an interesting statistic, is coronary heart disease. So 3% of women die from breast cancer every year. Women die more often from heart disease more than any other disease at all. So 1 in 3 women. So 30% of women are dying from heart disease every year. That's a huge statistic, right? I mean, I'm sure somebody has been touched by somebody that's died from a heart attack or a stroke, but this is a huge number. It just kind of blew my mind. And I think it's because, again, we talk about breast cancer, I think everybody's ingrained in their brain that they're supposed to be getting their mammograms. With heart disease, I think it's definitely underdiagnosed and undertreated. So that's a large part of this talk today, is to bring awareness to, heart disease in women and the preventative approach to prevent, showing up for the first time having a cardiac event. So somebody dies from a heart attack or a stroke every minute, a woman, all right? Every minute. So every 60 to 80 seconds, someone dies from a cardiac event. A woman dies from a cardiac event. I would tell you almost everybody in here, I would suspect, has some form of risk that predisposes them to having a heart problem. So 90% of women have some form of risk factor that predisposes them to having a cardiac event in the future. Most women will show up with their first heart event for the very first time, never having a symptom. Now, they say it's like 60%, that someone may show up in the emergency room for the very first time and has had a heart attack, yet leading up to the event, they were without symptoms. I kind of find that hard to believe, to be honest. I suspect women aren't really in tune to what symptoms to really pay attention to. Or I suspect most women probably brush things off, right? Like, you might have a little heartburn. That's what you're attributing it to, right? You get a little burning in the chest. You think it's just, oh, I just ate something that just didn't agree with me. You have a little tummy ache. Again, back to your GI system. Maybe you just ate something that didn't agree with me. Your arms ache, your scapular aches. You just assume, oh, it's my muscles or bones. You kind of just blow these things off. The fact is, these are things that I think we got to be paying attention to. Some women actually, their main symptom might be just fatigue. So let's kind of review some of the symptoms. So most women will have that typical like chest heaviness or pressure as their presenting symptom when they're having a heart problem. That is definitely classic for men. So all men mostly will present with primarily chest pain. And I'd say 50% of women actually present with chest pain, but other symptoms to kind of pay attention to. So again, epigastric pain. So almost like you're having reflux, tummy pain, nausea. So you might not think anything of that. Shoulder pain. The classic story is left arm pain, but it can be right-sided or left. Again, women are always different. They always want to kind of present with different symptoms. Breathing, shortness of breath might be your initial symptom you might have. So these are things to pay attention to. And then fatigue. Fatigue, I mean, I think Everyone's tired at some point. And again, you just brush that off. I'm getting older. I did too much today. But if you're having a symptom that you haven't had before, and you feel like it's becoming more prominent, you got to listen to your body. You got to talk to your doctor, because that might be the symptom that you're having, that you're unaware, that might indicate you're having a heart problem. So screening. So why do we do cardiovascular screening? So I just mentioned it before, right? 1 out of every 3 women dies of a cardiac event. 30%. That's astounding. So we got to screen patients. We got to sort out what kind of risk factors they have, so we can prevent patients from having this large amount of death that we see, okay? Most women, you know, again, I said, half the time women will just show up for the first time and have a cardiac event. And once a woman has her first cardiac event, she is at higher risk from dying in the first year than men. A woman is at a higher risk for having a stroke or heart failure. So heart failure is just where one builds up fluid in the lungs and gets more short of breath. So women are at higher risk for developing both those things in the first 5 years more than men. So this is something we really got to pay attention to going forward. So let's talk about risk factors. All right, so the classic things that, you know, men and women, that is the same in terms of who is at risk. Who's at risk for having a heart attack? So I'm just going to kind of go through the list of risk factors. So smoking, that's a big one. Tobacco use absolutely puts one at risk. Tobacco use is preventative, just so you know. That's a choice. Number 2, diabetes. So how our body kind of processes sugars. So diabetes puts people at risk. High cholesterol, we always talk about that. High blood pressure. Obesity. Obesity absolutely puts people at high risk for having cardiac events in the future. Physical inactivity. So if we're not exercising, you're at higher risk. Family history. So if you know somebody in your family, usually, you know, it's first degree relatives. So a parent or sibling who's had a cardiac event in their 50s or 60s or 40s or 30s, that predisposes you to having risk long-term. Now that's one thing you can't control. Your genetics you can't control, all right? So depression and stress. So depression and stress tend to lead to patients maybe, it can lead to higher blood pressure. It can lead to inactivity, becoming more overweight. So those 2 things tend to just contribute to the classic risk factors. Now, gender specific. So women in particular, who are at higher risk long-term. So if you had a baby before 37 weeks, if you had gestational diabetes, right? So if your blood sugars were a problem during pregnancy, or you had high blood pressure during pregnancy, you are at higher risk to actually have diabetes and high blood pressure long-term. Again, and that, again, predisposes you to having higher risk for having heart disease long-term. So autoimmune disease. So, let me pick one, like rheumatoid arthritis, for example. So when you have autoimmune disease, the inflammation in the body can lead to destruction of the blood cells. So that in itself can lead to premature, like coronary artery disease, putting you at risk for having a heart problem or stroke long-term. Breast cancer treatment. So there are certain therapies that patients get that are toxic. So the chemotherapy, for example, there are certain types of chemotherapies that actually can hurt the heart. So if you have ever had any of these things, I mean, these are things to kind of be very mindful of going forward. Polycystic ovarian syndrome, that's a hormonal syndrome in usually young women. This particular syndrome, women tend to be what we call insulin resistant. So again, it affects blood sugars, it affects cholesterol, and both those things lead to, buildup in the arteries long-term, which may predispose you to having a heart attack long-term. Amenorrhea, so functional hypothalamic, same type of idea, by the way, going through early menopause or menopause. There was a time where, years ago, 20 plus years ago, where there was a study that came out, and they thought that hormone replacement therapy actually protected women from having heart attacks long term. That has changed. So there is some role for hormone replacement therapy in perimenopausal or postmenopausal women to treat postmenopausal symptoms. But if you're 10 years out from menopause, if you're over 60 years old, there's actually risk for stroke with hormone replacement therapy, and there's risk for blood clots with hormone replacement therapy. So, deciding on, HRT long-term, that is a very patient-specific decision with your physician. Not that you can't go on hormone replacement therapy, but it depends on other risk factors, okay? Okay, so now I'm just going to specifically talk about risk factors, the ones we kind of just flew through. So smoking, so the most, preventable, right? We don't have to smoke. Smoking basically damages, the coronary arteries, not only the coronary arteries, so the heart arteries that supply the heart muscle, your brain arteries, your kidney arteries, your leg arteries. So smoking, it raises blood pressure, it elevates cholesterol. As I mentioned, it damages the blood vessels. It can cause arrhythmia. Again, the biggest thing that we don't have to do, and a lot of people choose to do, put you at risk. All right, 20% of women over age of 18 smoke, which again I think is astounding because it does so much damage. It just doesn't just cause cardiovascular issues, causes cancer, right? Lung disease. Long term, it's just terrible. Breast cancer. It's associated with different types of cancers. So smoking is terrible. All right, we gotta quit the smoking. There's no doubt about it. And it does put someone who smokes, you're at 5 times higher risk for having a cardiac event. If you smoke and you're a diabetic, it's even higher. It's terrible. So we really got to quit that. Smoking, and if you're using oral hormones for to prevent pregnancy, puts you at 30 times higher risk for having blood clots, stroke. Terrible. If you quit smoking tomorrow, you're going to lower your risk by 1/3 in about 2 years. And if you quit smoking 10 years ago, you're equal to it as if you have never smoked. All right. So diabetes, women are at higher risk for having a heart attack if they're diabetics, 3 to 7 times higher compared to men who are just 2 to 3 times higher for having a cardiac event. And as I mentioned, or I'm mentioning now, stroke, heart attack, diabetics are that much higher risk. All right. We tend to talk about diabetics, even with a definitive diagnosis of actually having a heart attack or a stroke, they sort of go hand in hand. So when we start talking about treating blood pressure numbers and cholesterol numbers, if you're diabetic with no underlying heart disease, we treat you as if you have underlying heart disease. Weight. All right, so this is a big thing for people, right? So if you look at these numbers on top, it talks about people overweight. It talks about people obese and morbidly obese. So that's based on your height and weight. So something called the body mass index. So we calculate that. So a BMI over 25 is considered overweight. If you have a BMI over 30, you're obese, and over 35, you're morbidly obese. Again, look at the numbers. 75% of the people in the United States are overweight and or to the degree of morbid obesity. We're talking 25% of Americans have healthy weights. That is astounding, right? It's unbelievable. And what goes along with this, the heavier you are, the higher your risk is to have a cardiac event, whether it's a heart attack or a stroke, all right? So, obesity is something I think everyone battles. It's not easy, but this is something, something that needs to be talked about and something you got to be aware of, all right? So let's talk about blood pressure. Let's just talk about blood pressure numbers. So high blood pressure, another risk factor that predisposes you to having a stroke or a heart attack long term. So normal blood pressure numbers, so you have normal blood pressure if your the top number, the systolic blood pressure is less than 120 and your diastolic blood pressure is less than 80. Pre-hypertension, the number goes up a little bit. So you know your systolic is between 120 and 140 and the diastolic is between 80 and 89. So stage 1 hypertension greater than 140, stage 2 greater than 160, all right? The blood pressure, again, high blood pressure, you're at higher risk. You're at higher risk for strokes, you're at higher risk for heart attacks, you're at higher risk for heart failure, all the above. And this is something that we all can be accountable for, right? We can get a blood pressure cuff, we should be monitoring our blood pressures. This is all about preventative medicine. I mean, you know, seeing doctors regularly, monitoring these things, because people walk around with high blood pressure and may never know it. You could have a blood pressure 200 and never know it. Some people might have symptoms, they might have had headaches, but not if you're chronically elevated and it continues to climb. You may never know until you're showing up in the emergency room with a cardiac, like a cerebral vascular event, like a stroke or heart attack. So what do we do about blood pressure? Simple, sounds simple. So it's about weight reduction, so losing weight, bringing our weight down lowers our blood pressure. What we eat, so what we eat lowers our blood pressure, all right? So certain foods, certain drinks raise our blood pressure. Alcohol raises your blood pressure, okay? Sodiums, so again, the amount of sodium we're taking in every day. So limiting our salt intake. Salt holds on to water, raises blood pressure. Physical activity, if you start exercising, you know, every day, it's gonna lower your blood pressure. And I just mentioned about the alcohol. So 1 alcohol drink a day, no excess alcohol, of course, because again, those things do raise your blood pressure. Let's talk about cholesterol. So cholesterol is a fat-like substance that kind of builds up in the coronary artery, or I keep saying coronary arteries, obviously, but it builds up in all your arteries, all right? You know, most of, you know, cholesterol comes from, you know, what we put in our tummy, so what we eat, but it's also made in the liver. Again, too much cholesterol leads to the buildup in the arteries that, again, put you at risk for having a stroke or heart attack. So there's good and bad cholesterol. We always talk about this. We go to the doctor and the doctor talks to you about, you know, your good cholesterol and your bad cholesterol. So the LDL is what we consider the bad cholesterol. So that contributes to the buildup in the arteries, all right? So the goal is trying to lower your LDL because that in itself will lower your risk for having a heart attack long term. HDL is the good cholesterol. So we want that good cholesterol. It actually helps remove the bad cholesterol. So let's talk about the numbers, all right? So again, this is different for different patients. So if you ever had a heart attack, you've ever had a stroke, you're diabetic, the numbers are different in what we're trying to achieve, all right? So let's just assume everybody in this room doesn't have cardiovascular disease, never had a stroke, and are non-diabetics. So the goal is to try to get your total cholesterol less than 200, all right? Now we're gonna just focus on the bad cholesterol. The ideal goal is to get the LDL, the bad cholesterol, less than 130. So moderate elevation in the LDL is like 130 to 160, anything above, typically 180. Then we're talking about, you know, some kind of, you know, intervention in terms of medications. HDL. So HDL is different for men and women too. So HDL, you know, ideally we want women's HDL to be above 50, and for men it's above 40. Again, diabetics. Now let's talk about diabetics and people who have known underlying cardiovascular disease. There's been a new guideline, new change regarding this. So the ideal goal used to be less than 70, the bad cholesterol, LDL. That has changed. Now we're trying to push people to get the LDL as low as possible, but the ideal goal now is less than 55. The lower your LDL, the lower the risk of you having a future cardiac event. And when I say event, I'm talking a heart attack or stroke, okay? So I get lots of questions about diet, right? You know, doctor, what should I eat? What is the good things I should eat? What should I not eat? So I had a partner that was a big believer in plant-based, you know, diet, which there's definitely some role in plant-based diets. I tell my patients that they need to eat a heart healthy diet, which specifically in my mind is like a Mediterranean diet. So you want a diet full of lots of vegetables, lots of fruit. And when I say fruit, I'm not talking fruits in cans, right? Because the can and the frozen fruits have so much like added, processed sugars, which is very bad for you, okay? And then, you want, servings of whole grains, so whole wheat, brown rice, a lot of fish and chicken. If you're gonna eat chicken, you don't wanna eat the skin on the chicken. Fish has a lot of omega-3 fatty acids, which is really a lot of brain health, a lot of heart health in terms of that. We can't, we get most of our omega-3s through what we're eating. So lots of fish, all right? It's great for you. If you are gonna eat meat, it needs to be very lean meat, all right? And then we talk about the sugars, right? I mean, how often do we eat? Everyone's busy, right? Everyone's, working or busy doing something, and it's really difficult to go home and then have to think about cooking a meal. So you just, you go through a drive-through. I mean, there's all that stuff. There's so much, the processed foods are just so bad for us. There's so much saturated fat, which is the trans fats, which is the bad fat. It's best if we can cook at home, right? Cooking in, what we call, polyunsaturated or monosaturated fat. So, cook it in an olive oil, all right? Those are the best things that we can do is cooking at home, all right? Limiting salt, I kind of talked about that. So I tend to preach less than 2,000 milligrams, but ideally less than 1,500 milligrams a day, all right? You got to look at the cans. If you're going to eat things, look at the cans because there's so much salt in canned foods, a ton. You guys just don't even realize it. I have patients come in all the time, and, they're more swollen or their blood pressure's up. And if you really start having a conversation, you kind of can tease out that they're probably getting more salt in their diets than they actually realize. So this is what we call a diet score quintile. This is just reflecting on that the healthier you eat, the lower your risk for having a cardiac event. So the quintile, basically 5 really, if you have a quintile of 5, this means nothing to anybody here, but this is all healthy eating, all right? Your quintile is 1, it's unhealthy eating. So again, poor diet, processed foods, lots of sugars, you're putting you at risk for, up in your lipids, up in your blood pressure, I talked cholesterol, blood pressure, and the sugars, of course. And again, higher risk for having a heart attack, stroke. Exercise. So this is definitely another, issue. I think it's very difficult for people to do. My joints ache. I don't have any time. I'm busy. I'm tired. But exercise is super important. Exercise also, as I mentioned before, right? It alters all those risk factors, right? If you're exercising regularly, it lowers your weight, it lowers your blood pressure, it lowers your cholesterol. We should be exercising. So when we talk about like moderate exercise, like a brisk walk, riding a bike, we should be doing that 30 minutes a day, 5 times a week. If you're a runner or you're playing like some heavy, like tennis or whatever it may be. So if you're doing more vigorous exercise, it's like 75 minutes a week. But we should be finding the time to do that every day. And we want to get, the whole point is we want to get our heart rates up. So there's this goal about trying to get your heart rate, your maximal heart rate, between 50 and 70%. So that's 220 minus your age. So for example, a 50-year-old, right? So a 50-year-old, 100% of a 50-year-old's predicted maximal heart rate is about 170 beats per minute. So someone like that, in terms of like exercise, they should be getting their heart rates probably about up to like 120 beats per minute, if they're really working the heart. But we should be doing that every day, and we don't find time to do it. And again, there's correlation. The more exercise you do, the lower your risk for having a cardiac event. So you got to start today. I mean, I hope everybody sees, does a wellness check with their physician yearly. So important, okay? I find that not a lot of people do. I see even older patients, I'm meeting them for the first time, in the emergency room, and they're not doctoring, they're not seeing their doctors. You guys, patients got to be accountable, right? You got to be accountable for your own health. So, you got to start today. So, seeing your doctor regularly, having the blood pressure checked, having your cholesterol checked, looking at your blood sugars, all these things are very important. I think that number that I showed up in the beginning, right, 30% of women are dying of some kind of cardiac event every year. I think it's because we're not doing the preventative things. I really believe that. So you got to start being active, right? You got to start exercising regularly. Find the time, whatever that may be, all right? Even a brisk walk, 30 minutes a day. Everybody can find that time to do that. And then we talked about, the diet's super important too. Really try to be mindful of, if you're eating canned things, because not everybody can make dinner and it's difficult. Looking at the cans, looking at the labels. I have a little handout here. You can kind of explain some of that. I think that's important. Trying to eliminate the things that like trans fats. So we're talking like snack foods like chips, right? I mean, you name it. Going through the drive-throughs. The fried foods, right? The cakes. The cookies, all this stuff we should try to eliminate as much as possible. Back to limiting salt, we want to do that. Limiting alcoholic intake, 1 drink a day, very important. Try to maintain a healthy weight. I think it's very important. If you smoke, stop. I mean, I could get on a soapbox about that because I just don't understand why anybody smokes anymore with all the bad things, that come along with smoking. And then again, it's about, doing your regular checks. If you're on medicines for some of these things, being compliant with your medicines, right? I think that's very important long-term. If you're diabetic, monitoring your sugars, again, going to the doctor, doing all the right things. So that's it. Does anybody have any questions? Oh, yeah.
You mentioned in the very beginning something about screening.
Yeah.
Is there a screening for that?
Yeah, so it's a great question. So I have patients come in, there's a couple things that people do. I have people come in, I think maybe somebody has done this. You can actually do these health screens where they'll check, there's like a company will check your blood pressure. They will look at the blood flow down your legs. They will look at your aorta to look for aneurysm. So there's these types of screenings that you might spend $100 on. And they're good. There's something called a calcium score. So there's a CAT scan that I see a lot of patients coming with these CAT scans. Again, another screening tool. That particular test looks at calcium in coronaries. So screening, who does the screening? Your doctors. You need to be seeing your doctor regularly. You don't need to be doing these screening things that you might see out there for $100 or $50. You need to be seeing your physicians. I mean, but let's say you don't, and you wanted to, get some kind of baseline, examination to evaluate your cardiovascular health. You could do some of these things. You could. Any other questions?
Salt. What's the problem with salt?
Salt holds on to fluid, and it raises the blood pressure. Yep.
You shouldn't have salt.
You should limit your salt intake. Yep. So no more than 2 grams a day. Yeah, I know. Other questions? Yeah.
So your blood pressure and your cholesterol controlled by medicine?
Yes. So yes, if the answer is yes. Okay. Now, as I just mentioned though, if you exercise, if you lose weight, I mean, you are still going to get reductions in blood pressure and maybe come off some blood pressure medicines. But you're right, there's some patients, right, that, you know, as we get older, ours get stiffer too. Sometimes you can't get off medications. So the simple answer is yes. You know, if we're achieving these goals, right, getting that blood pressure less than the systolic less than 120 and that diastolic less than 80, then yes, that's appropriate. Mm-hmm. Yeah.
If you go and have one of these walking stress tests,
Yes.
it says that you're good, are you good? Or you turn around and have heart attack.
So that's a great question. So, you know, exercise stress tests aren't 100%. So there's different types of stress tests, right? There's a treadmill where we walk you, and then sometimes patients can't walk because of bad knees or bad hips, and there's medication stress tests. So stress tests are very sensitive and specific for picking up cardiovascular disease, so obstructive coronary disease, so narrowings in arteries. Now, those types of tests tend to only pick up if the artery is significantly narrowed. So typically 70% or greater will lead to an abnormality on a test, all right? One, they're not 100%. So the answer is, yeah, you could pass a stress test with flying colors and still have a cardiac event, okay? Stress tests do not pick up moderate type narrowing. So if you had a 50% narrowing in an artery, you could pass a stress test with flying colors. Could you 24 hours later have a cardiac event? You could. There's different types of heart attacks. So patients, so there's what we call, you know, calcified. So when I talk about a buildup in an artery, you know, the buildup tends to be, can be calcified. So, and a calcified plaque tends to build up over time. It doesn't happen overnight. So, you know, over, 5 years, 10 years, 15 years, and, you know, you could have a narrowing of 40 that progressively gets tighter and tighter and tighter. And at some point, when it's 70%, you might start having a symptom, okay? Then there's what we call soft plaque, all right? Or unstable plaque too. So, you know, these are the young people, not even just young people, but all people can show up, you know, in the emergency room having a heart attack, and they could have passed a test the day before. The buildup sometimes can become unstable, and that 50% narrowing, the plaque ruptures, and all of a sudden the platelets start to stick together, and so you go from a 50% narrowing the day before when you ran 10 minutes on a treadmill to 100% narrowing, and all of a sudden you're having symptoms. So that's a long, you know, answer to a short question. The fact is you can absolutely have a cardiac event if you pass the stress test, all right? You know, a walking test, I will tell you this, if you get on a treadmill though, and you walk 10 minutes on a treadmill, I mean, prognostically, that's very good. I mean, the likelihood of you having a cardiac event within the next year is actually pretty low, all right? So an exercise stress test gives us a lot of information as opposed to a medication stress test. But yes, theoretically, you could still have a cardiac event even if you pass the stress test. Yes.
And what's the difference between, like I have those run wrist blood pressure cuffs, you know?
Yeah.
And I know what I do all the time, daily. But when I go to the doctor, it's like 20 degrees lower. It's better when they do the arm one.
Yeah. So the manual blood pressure cuffs are the most ideal blood pressure cuffs, no doubt about it. You're going to get the most accurate reading of your blood pressure. Now, to your point, you go to a Walgreens. I mean, a lot of them are wrist cuffs, right? Some of them are arm cuffs. They're electrical. You know, if you get a blood pressure cuff from a pharmacy, it would be nice if you try to correlate the cuff with a blood pressure cuff in the office. You know, I have my patients all the time come into my office. I tell them to bring their cuff so we can compare to make sure they are reliable. Okay. And if they're reliable, great, we can use them. Now, cuffs do get old, right? So, you know, over time, you know, they have to be replaced. But the manual pressure cuffs are definitely better, no doubt about it, and more accurate.
You said that brisk walking is the best for walking. I go to the Y and we have a track and you have to go 8 times around to make a mile. I can do a mile in 15 minutes. And I try to do 3 miles a day. And also we have silver sneaker classes.
Yeah.
that there's chair yoga, chair Pilates.
Yeah.
And then they have strength training. Now, I try to do all that at least 3 times a week.
Yeah, that's great.
And I'm losing weight yet, but I don't brisk walk all the time. So even though I'm doing a mile in 15 minutes, is that considered brisk walking or?
So,
I mean, I'm going like this.
so do you feel like you're getting winded when you walk? I mean, do you push yourself?
Right.
I'm asking you, do you?
I push myself.
Do you feel like you're like it's hard to do?
Well, when I get to a certain point, then I push myself I look at the clock and I know, okay, I gotta get there. But sometimes it's crowded.
Sure. Sure.
But I'm just wondering, I do walk. I mean, I'm not just walking.
I suspect if like I calculated, if you did that walk, right? And then I stopped and I took your pulse and I calculated that heart rate we talk about of trying to get that predicted maximal heart rate up. I suspect based on what you're doing, you are doing that. All right. So that would yes, that's probably considered moderate.
Because I'm not like out of breath and I gotta sit down.
Got it. Okay.
I mean,
Do you feel like after you've done the workout or done your walking, do you feel like you exercise?
Oh, yeah.
Yeah, then yeah.
Especially with the chair yoga.
Yep. Yep. That's what.
Not the standing, it's not like everything
Yep.
when you sit in a chair, it's not that.
Yeah. I mean, my brisk walking might be different than your brisk walking, right? Because we're different ages, obviously, right? So that number we're trying to achieve to really kind of work the heart is different. But the answer is yes. It sounds like you're getting that, not vigorous, but that moderate, exercise that I'm talking about, which is very good. Good that you're doing that. Yes.
You incorporate inflammatory markers for your own patients for treating chronic inflammation in the body and blood vessels?
So I don't tend to order blood tests like what we call a sed rate or CRP. I don't tend to order those routinely. I do not.
Do you think that's a wise thing to do if you, Medicare won't pay for a lot of these inflammatory markers, but the interventions might tell you that if they're effective, your inflammatory.
Yeah, the number will go down. Sure. True. Yes. But I'm not, insurance companies, that's a whole different conversation, but, I don't order those tests because I don't know necessarily how it will necessarily alter how I manage the patient. We know, right, if we get the LDL down. So there's a blood test and a number, I know the number to treat, and it reduces risk. Other questions? Yeah.
If we regularly see a physician for annual checkups and we're asymptomatic, should we still be establishing a relationship that we do as a cardiologist as a backup? Or do you just show up in ER one day and have to?
So, I'm going to try to, if you have a lot of faith and trust in your physician, which I hope you do, no, you don't have to. I do see sometimes patients will establish with me if there's a strong family history. Do they have to? No. So as long as you're doing that regular follow-up with your regular physician and they're doing all this preventative, looking at your blood pressure, looking at your cholesterol, looking at your blood sugars, these kinds of things, then no, you do not. But if there's concern on your end that maybe some of those things aren't being done, then if there's a strong family history or you have risk factors, right? You have high blood pressure and maybe it's not being managed, as aggressively as you might think it should be, then you can absolutely establish with a cardiologist.
And then what do you ask for? I just want to establish a relationship.
Yeah, I would say you tell the front desk, I have high blood pressure and I want to establish with a cardiologist. Yeah, some insurance companies, not Medicare, but some insurance companies want referrals and stuff. My office, I don't need referrals. Yeah.
Would you suggest for
someone who has like rheumatoid arthritis and maybe can't walk briskly for 30 minutes? What do you suggest for them?
So a pool, I would say, like getting in swimming. So getting in a pool, because that kind of thing is going to be so much easier on joints. I'd like to tell you maybe a stationary bike, but not for everybody. To your point, I feel like patients talk about the pool. Pool really is beneficial. It's so much easier on your joints. There's a lot of different places that have pools here that actually have classes. Yes.
The YMCA has special classes, and they have passes that you would get at the front desk. They have the Silver Swingers program, and so there's like it's small pools, but there is a lot of activity. It's not like, we're all in a class, but everyone takes the pools or the classes, and they're adding more and more to the life. So I suggest everybody check it out.
Yeah.
Can you have too much good cholesterol?
No. No, the higher the better. No. It's actually, the good cholesterol, the HDL is cardioprotective. It can actually kind of, it counters the bad cholesterol
Because I have higher cholesterol overall.
because of the HDL. That's okay.
I was recently told the opposite, that now they're looking at over 60 is too high.
No. Higher the better. Yeah.
You mentioned the chemotherapy and the damage that it may do to the heart.
Yes.
I got 20 rounds of this 15 years ago. Does the heart repair itself? I have no idea if I don't remember the mention.
Yes, it's certain types of chemo that can be toxic to the cardiac muscle and can weaken the muscle. Okay. I will tell you, for example, radiation too can absolutely damage blood vessels too. I've had patients who've had radiation be more predisposed to having cardiac problems long term.
Yeah, no radiation.
You know,
15 years ago. I mean, I don't
Yeah.
know if I have anything now.
Yeah, so when people are undergoing chemotherapy and the chemotherapy is cardiotoxic, the oncologist is aware of that. They tend to get imaging of the heart when you're going through therapy. And then it goes back now to your point, like, just because you had chemotherapy 15 years ago, and I don't know if it was a cardiotoxic, like toxic to the heart, but you're 15 years out and you're feeling good. We don't routinely keep repeating imaging. We listen to patients and if they're having symptoms. Yeah.
You have a CAT scan, MRI.
Yep.
Does that pick up on anything? So I know I always come back to heart.
CAT scans.
CAT scan, MRI,
So,
CAT scan.
CAT scans of what though are we talking about? So sometimes people get CAT scans and
Why did you get under the chest?
yeah, and so they'll mention that your heart's not enlarged, right? Sometimes CAT scans might mention that your heart's enlarged, which might lead to further testing. CAT scanning, we don't tend to, I shouldn't say 100% we don't do cardiac CAT scans because there's some indications that you can actually look at the coronary arteries, look at the flow in the arteries. Cardiac imaging, the one cardiac test that, again, I mentioned earlier that, we talk about screening. So there's something called a cardiac calcium score. So I see a lot of patients get this particular test. It just calculates the calcium in the coronary, okay? That doesn't tell me anything about the function of the heart muscle, nor do CAT scans for that matter. A CAT scan might tell you there's a little fluid around the heart, but again, not 100% reliable, I will tell you. That tends to lead to, other cardiac tests that are more definitive, all right? There are tests though, like there are cardiac MRI tests, which are very good tests. But again, we order those things for particular reasons, of course, though. Yeah, looking maybe at your lungs or your aorta. I'm not entirely sure what it's being ordered for necessarily. Anybody else?
Does having AFib indicate a possible heart attack or stroke? Having AFib?
So atrial fibrillation is an arrhythmia, okay? And that particular arrhythmia does put certain people at risk for having a stroke, okay? Again, it's sort of, that's a whole different can of worms, by the way, a whole different discussion. If you go into atrial fibrillation, doesn't necessarily mean that's a precursor to having a heart attack. That's a totally different discussion. But AFib does predispose you to having a risk for a stroke. It does. And that's because the chamber doesn't, it doesn't squeeze normally, and the blood can become very slow in this little chamber where the chamber fibrillates. And so the blood becomes very static, little clots can develop, they can break and go to your brain and put you at risk for a stroke. So, Any other questions? It's okay. All right, everyone, eat healthy, exercise, preventative medicine. All right? I have these.
But you gotta ask you one question.
Yeah.
Because I was here, because I don't like talking for the I gotta ask you one question. What is the difference between a regular